Good day. Betty Nuovo, and with me I have Claire Ayer,
Betty.
Claire Ayer,
Hi, Betty.
and she's going to be our guest today. So, how are you?
I'm great, but I have to tell you, Betty, we miss you in Montpelier because there are not that many people with the kind of background knowledge you have, and the ability to parse out the legal language in a bill. But what I miss the most is Betty Nuovo always told it like it was. You were the one with the nerve in that place.
Oh, thank you.
Yeah.
Well, somebody else must be able to.
I don't know. Nobody I hang out with.
Okay.
Yeah.
All right. So today we have you on for a show, and we want to talk about a few things. The gag rule. Mm-hmm. What you are doing in the Senate.
Sure. We started off the year, the first few weeks, working on drug prices. That's one of the areas that we have seemingly very little control over, but yet it grows in leaps and bounds. We've all read in the newspaper about egregious increases in prices of drugs that have been on the market for some time, so no research, no new research or development or marketing, and that the prices double and triple and go up a ton. So we did several things. We started with a program that would, let me back up a little bit. In the Affordable Care Act, there was a little piece that said states, with the permission of the federal secretary from Health and Human Services, could do their own drug importation programs. So we thought, well, we'll take a look at that. We passed a bill that says Vermont will do it, and that the Agency of Human Services and the Department of Health will spearhead the effort. And the way we intend it to work is that we'll get information from our top insurance companies, the teachers' insurance and the state employees' insurance, Blue Cross Blue Shield, as well as Medicaid, get their top 20 or so drug spends, whether it's by how much they're used or how much the price is. And of course, that's confidential, so we'll send that to a third party. And what we'll do is combine the lists, look for our big heavy hitters in statewide spending, and compare the prices to Canada. So I happened to see a list of the top 10 drugs from one of the insurance companies, and we just went online and looked at Canadian prices, and they're anywhere from 10% to 30 or 40%.
Cheaper?
Of the cost, so 60% cheaper and 90% cheaper, really. But on average, if you look across the whole spectrum of drugs, they say the average is about 30% off. But 30% of millions and millions of dollars is still millions of dollars. So we'll look at that, and it would only be for 10 or so drugs. Pharmacies would know, part of it is the education of the people who write the prescriptions and who fill the prescriptions, so that consumers will know if they're going to have a drug that accomplishes a certain goal, a drug for blood pressure or high cholesterol or whatever, that this particular one is the best price. And then everything else is the same. Just those 10 or 15 drugs. And generic drugs in Canada are the same or even sometimes more. So we're not even looking at generic drugs. Mm-hmm. The second thing we did in that bill was to allow the Agency of Human Services and the Department of Health in particular to work with a pharmacy or a wholesaler to look at doing our own wholesale drug own wholesale drug buying here in the state of Vermont. And we didn't get into the particulars of that, other than that we were looking to save money, and that the supply chain and where you and I go to pick up our medication when we need it wouldn't be any different, and it wouldn't be any different for the insurance companies, the payers.
And has that worked out?
Well,
Or
it's still, the bill is in the House.
Yeah.
The bill is in the House, but that would be a lot of setup work for the administration.
So it would take time.
Yep.
Yeah.
The third thing we did was follow on the model of a California law that requires pharmaceutical companies that sell drugs to the state, and for us that's through our Medicaid program, to notify us 2 months in advance if a drug was going up by a certain percent and explain themselves. Well, we did get a notice just a couple of weeks ago about some pretty large increases in some very common drugs, but we didn't get much by way of explanation. But we're on alert now, and I'm not sure exactly what we'll do with that information, but maybe we'll be looking for a substitute and advising insurance companies and prescribers to use the substitute because it's so much less. I don't know that we'll do that.
Or whether it will be too much less.
Yeah, exactly. And the fourth thing we did was dealt with something that we call the gag rule. Pharmaceutical companies and manufacturers deny this, and wholesalers deny this, but pharmacists told us that when they work with certain prescription drug management companies, if I went in to buy some medication and my copay was $10 or $20, they can't tell me that I could pay cash for it for $10 or that I could get a different brand for $12. They, as I said, the companies they work with deny that that's the case, but it is the case. So we made a specific law against it. Yeah, it's kind of fun.
So it takes time for a law to go into effect.
That's right.
So has that been in effect yet, or?
No, those are all Senate bills, so they're in the House right now, and they're getting a good reception and a lot of interest. And the usual suspects will work for them and against them, and we'll see where they end up with the bill. But I'm feeling pretty good about it.
And then you have a committee of conference.
Yep.
If there's a change.
Yep.
With the House and a difference in the House and the Senate, you have a committee of conference.
Yeah. Well, my guess is that changes made to it would be in details and subtleties that aren't that important in the big picture, unless they decide they don't want to do it, which would call for a committee of conference. But I don't expect there are going to be big changes. There are only so many ways to do this drug importation program because you have to get permission from the feds. That process will take over a year.
Oh, so it won't go into effect for at least a year.
No.
Yeah.
No, but it'll take the Department of Health and the Agency of Human Services that long to set it up and figure out how it would work.
Yeah.
Yeah. So it'll go into effect when they can get it into effect, and I think our ideal was 2020, first part of 2020 maybe. I can't remember, but as it goes through the process, they may fine tune the dates.
Yeah.
Yeah.
Well, that's good. It's a way to help people with their costs.
Exactly.
And to get the best deal and good product.
Right. Right. And that's, one of the biggest objections to that was, we'll end up with unsafe drugs and, people won't know what they're getting, which is, of course, from the drug manufacturers. And what most people don't realize is that about 40% of the drugs that are approved by the Canadian equivalent of the FDA are also approved in Canada, in Canada, right? And a bunch of the drugs that we use here in Vermont and in the United States were made in Canada. And finally, most of the drugs that we manufacture in the United States have most of their ingredients from abroad. They come from other sources. So this isn't a new thing. It's a global market.
Yeah.
We're not buying them from the jungles of Africa or something where they may not have good standards. This is only drugs that are approved by the Canadian equivalent of the FDA.
Yeah.
And we've had an agreement, the United States has had an agreement with them since the 70s, I think it was, about exchanging drugs and so on. So it's safe. I don't have any doubts about the safety of the program, which is about the only objection that people came up with while we were taking testimony. Yeah.
So, well, that's a good thing. And then you have another item is wholesale.
Well, that's the part where we authorize the agency, Department of Health, and the agency to work with drug wholesalers in the state or pharmaceutical pharmacies in the state to see if they can develop a wholesale program. We've already been approached by a couple of pharmacies in Vermont, so we know there's interest, and it looks like there's capacity. So what remains is to iron out the details.
And that could take a long time or it could take a short time.
Right, exactly. The people who are very optimistic about it think it's going to take less time, and the people who are pessimistic think it's going to take more time. Yeah. Nothing's changed since you left. Yeah.
Okay. And then you have the pharma notice.
Yep, we talked about that, and that is the pharmaceutical companies notifying the state of Vermont if they're raising their prices by a certain amount, and letting the Attorney General know, and the Attorney General posts them so that prescribers and consumers will be aware that the drug that they used to take for their cholesterol now costs 2 or 3 times as much. And maybe they'll have a conversation with their healthcare provider to switch to a different drug, or not. There's nothing that says that anybody has to, but at least that information is out there. I mean, how many times have you heard from people who say, I just went to the pharmacy to renew my prescription and it was twice as much as it was 6 months ago. They have no idea that the price went up. It never occurred to them to check in with their healthcare provider, their doctor. Their doctor wouldn't probably know either.
Yeah.
So this will provide some sort of notification for everybody in the healthcare system and help us help ourselves.
How would the notification work?
They have to notify, the pharmaceutical manufacturers have to notify the Attorney General. The Attorney General's office has to post them.
So they have what the raise is.
Yes. Yep. And part of it is they're supposed to explain themselves. It's sort of a legislated way of trying to shame them for doing that, but I don't know how effective that's going to be. I do know that the law went into effect in California, and they've had some interactions about it, but I don't know that it's changed anything so far. But it's worth a try.
Yeah.
But consumers can vote with their feet or with their prescription pad or their insurance card. If there's another drug that'll do the same thing,
yeah,
they and their healthcare providers will know and maybe choose another drug.
And then the one that raised the prices will have to lower.
Maybe they'll reconsider.
Yeah.
I haven't seen a lot of that.
No.
Yeah. Yeah.
Okay. And then there's the
Yep, we covered that, I think. Yeah, the imports, that was the first part, the Canadian imports. Yep.
So the Canadians also make these drugs.
They manufacture drugs just the way we do in the United States. So some of them would be made there. Some of the drugs that they sell there are made here. I heard this great, or I saw a great sort of analogy. Imagine if you bought a new Apple Watch for $1,300 here in the United States, made by Americans, made for Americans, made in America, right? And it cost, I don't remember the price, $1,200. And then you drive up to Montreal and you discover you can buy it for $45. That's the same thing that's happening with drugs, because all the other countries in the world have healthcare systems, and so they dicker, they barter, they bargain with big pharmaceutical companies, and they're not allowed to charge the high prices in those countries that they can in the United States, because we let them.
Oh.
And that's a matter of federal legislation.
Yeah, I've worked on some of that.
Right.
A little bit, so I understand it, but it's hard to explain.
Well, it's hard to explain, but it's also hard to do, because we're so outweighed by the influence and power of big pharma in our little state. But in fairness, people said, "Oh, it must have been terrible, all those lobbyists and everything else." And the fact is, you know what it's like. Yeah. In Vermont, the lobbyists are, sometimes they wear black hats, sometimes they wear white hats, but they're always a source of good information for us, because if they ever lie to us or mislead us, they are finished. They're done in the White House, in the State House, because nobody trusts them. Yeah. So it's a different kind of relationship.
Yeah, yeah, that's true. That was happening when I was there.
Yeah, it's always been the case.
They had to tell the truth.
Yep.
Okay. Savings.
Oh, the universal primary care.
Yeah.
That was a bill.
What is that?
Well, the notion of this bill, universal primary care, is that every Vermonter would have access to a certain set of very basic primary care services. So when you go to the doctor and she checks your blood pressure, looks in your eyes, listens to your heart and lungs, maybe a blood sugar, maybe a little finger stick to check your iron level, check your urine for sugar and so on. That's all part of a basic healthcare checkup. And this would be, this and other, you go in for some sort of infection. Those kinds of things would be covered under universal primary care. Now, if you were sent for an x-ray or some other tests or to a specialist, then you go to your regular insurance policy. And the notion is that people who have regular primary care contacts will stay healthier because they'll pick up things earlier, like high blood pressure. There are often no symptoms of that, and people are really surprised. But the notion is that we'll know early, and we'll know at a time when something like high blood pressure is treatable, instead of waiting until we have damage, a stroke or a heart attack or things like that. Or with diabetes, there are so many complications. But if we know early, they can be either reversed through weight loss or diet or that sort of thing, or controlled with medication. And studies all over the world show that people who have good access to primary care, their total cost of care is much less, a third to a half or more around the world.
That's because they don't get sicker and sicker and sicker, and then the price of getting better goes
exactly
up.
Exactly. And we even have some work that's been done in the United States that shows that in North Carolina, Tennessee, Ohio, Rhode Island, that when people have increased access to primary care, their total costs go down. So, for example, this insurance company in California decided to put a lot more money into primary care. They almost doubled what they spent on primary care for their Medicare patients. And at the end of just 1 year, or it might have been 2 years, what they spent for total health care was much less than what regular Medicare patients got. So they put more money in and ended up spending less in the end. And everything in healthcare is more complicated than that. But those are the kinds of things that we've seen all over the United States in small, 10, 20, 50,000 people, 100,000 people, small groups under limited circumstances, usually in the context of insurance, everybody in an insurance plan or everybody on Medicaid in the state, that sort of thing.
100,000 people is a smaller.
Well, in California, for example, yeah.
It's different in each state. What would be a major?
So we don't have any reason to doubt that could be true. If everybody in Vermont got universal primary care, that in the end would save more money than we spent and would be healthier, right?
Yes.
And over time would spend less, because the bulk of what we spend on healthcare right now is spent in hospitals and is spent on chronic care. And those diseases, by and large, are preventable. The diseases that result from high blood pressure, overweight, smoking, diabetes, those sort of things, can be either prevented or mediated, and that's where the big chunk of money is. So it sounds like a great idea. I think it's a great idea. The bill was diluted somewhat in appropriations because my bill called for a publicly financed system of primary care, so everybody could get it, and we didn't have any budget machinations going on around it. That piece of it didn't make it through appropriations, and so what they did was they assigned the whole project to the Green Mountain Care Board to let them look at it, instead of spreading it out among different government agencies. And the language says whatever works, basically, whether it's just paying for copays and deductibles, because we know that most Vermonters are insured. We have one of the highest insurance rates in the nation. But when you have a $2,000 or $5,000 deductible, you wait before you go to the doctor. Something has to really be wrong. So we know that's true. And we also know that we are looking at a shortage of primary care physicians. Part of this bill would be to make sure that we We pay our primary care workforce, so that's nurses and PAs and doctors.
PAs.
Physician's assistants, thank you. All of those people, pay them well enough for them want to come here and stay here. Primary care providers are the low people on the totem pole when it comes to payment, even though they spent the same for med school and so on.
Education,
They're low on the totem pole. So that's an issue we have to deal with outside of this bill. It's all wrapped into the bill, and asks that we work on the paperwork and the kinds of things that really demoralize primary care providers, make life better for them through their salary and their working conditions, and make sure that we can all go to them on a regular basis in an attempt to stay healthier.
And is Vermont the only one that's doing this? Or California? Or?
What we've seen are different healthcare plans pretty much trying that, putting more into primary care and seeing what the results are. Rhode Island did that through their Blue Cross Blue Shield plan, and they found in 1 year a decrease of 14 or 18% in their total cost of care for that group of patients. So we haven't ever seen it in a whole population for a whole state, but we've seen it in enough large groups over the country to think that what works all over the rest of the world could possibly work in the United States.
And some of these large groups have more population than Vermont.
They could, and I wish I'd looked at that data before I came in, Betty. I can't remember how many people were in that program in California. Could well be almost as many people as Vermont. I don't remember.
Because we were the smallest few
we're
states in the country.
That's right.
Yeah.
That's right.
So when you talk about the number of people, you have to understand that we have a small group of people.
We're the size of a small city in terms of population.
Yeah. But we work well.
Yeah, we do. I like to think we do. So that bill was diluted somewhat from a commitment to publicly financed primary care for everybody. It passed the Senate, and now it's in rules in the House, which means for people who don't understand how it works, we have certain dates by which House bills have to get to the Senate and Senate bills have to get to the House. Right. And if they are late, they get held up in this committee to see if someone will beg hard enough to get them out. And that bill did pass all of the deadlines and got there in plenty of time. So tomorrow, there'll be some work in the House to get it out. A Senate member can't appeal to the House Rules Committee to get her bill out. It has to be members of the House. So I'm hoping that there'll be an effort to get it out of the committee. I have the paperwork. I gave it to a colleague in the House to go there and say, see, we made, the Senate made all the dates. Let my bill go. We'll see.
Yeah.
Yeah.
Well, they have to take good care and make sure that you're right.
Yeah. Well, of course I'm right.
And then it works the other way around. When the House has a bill, the Senate makes sure.
Yes, and in fact, I know they make mistakes on both sides because I had to go ask for a House bill just last week saying, I know it made all the dates, and it's a mistake that you have it in rules. I need the bill. So.
Oh, yeah. Well, why don't we explain what rules are differently than bills?
Maybe I should let you explain it.
Well, rules are
the Rules Committee or rules in general?
The Rules Committee, I would assume, would be taking care of something.
The Senate has a Rules Committee and the House has a Rules Committee, and they sort of make procedural calls on how bills move and what the proper sequence is and who the bills belong to, what committees, and which bills have priorities over others and that sort of thing. And House and Senate rules are a little different, but my understanding is that the crossover rules are the same. And crossover is that date by which bills have to get to the other chamber. And that's just so we have enough time to work on them. When they get there late, they might as well not get there at all. If we can't just rubber stamp things and just pass them on.
Yeah, and that date is usually before town meeting date.
It was right around town meeting. It was right before town meeting, as a matter of fact. It was March 2nd to get it out of committee.
Friday, I think it's the Friday before the Tuesday town meeting.
That's exactly what it was
Yeah.
this year. Yeah.
Okay. So then, let's see here, we have 5 minutes left, believe it or not.
Oh, well, maybe I should tell you about, I just contacted Legislative Council today, our lawyers, and asked them to draft something, to make some language up for me. I read an article in the newspaper this week about, it was about advanced directives. And so that's not the same as death with dignity. This is the kind of thing that most people my age and younger, I've had one since I was in my 50s, right? If anything ever really bad happens to me, if I'm in a car accident, I have a stroke or a really bad heart attack, these are the things I want you to be sure to do or be sure not to do if I can't make my own decisions. So, for example, I might say, no matter how sick I am, I want you to do everything. Put in every tube, give me every drug, give me every treatment, do every operation. I want to live, and don't hold anything back. Or I can say, in the event that I'm incapacitated in these specific ways, I don't want any tube feedings, I don't want any IVs, I just want you to keep me comfortable. And I'd like them to brush my hair too, but I didn't put that. But I didn't put that in the advanced directive. So anyway, those are things.
Or something that's in between.
Right.
The
Yeah.
two.
And anything in between.
Yeah.
It's under these conditions that you name. I want these things to happen or not to happen. And usually, what you do is you share them with your healthcare providers, your doctor or whatever, and you make sure your family knows. So I remember when I sent mine out to a couple of friends and all of my kids, I got about 5 phone calls in 10 minutes. What happened? Are you sick? So anyway, I've had that done. And what I learned is that very often if you show up at a hospital, even with electronic medical records, they are not seeing them. They're not, they don't know. I come in, I'm unconscious, and so I'm intubated, or they do sort of life, or they resuscitate me, even though I didn't want it. Because I'm dying of cancer or I have brain damage or something, but they don't see them, and so they don't do me any good.
But you can send it to the
That's right. You send it to the doctor, but it's not necessarily in your electronic medical records, let alone your paper records.
But you could send it to the hospital.
I have,
Yeah.
and I've done that, and most people believe that that's taken care of.
Oh.
So this language would ask the people who work on keeping our electronic medical records in a useful form that can move from place to place to make sure those are in there, and to let people like us know how we can make sure they're in there. So mine are in a federal database that's out of New Jersey or something, and they register them. The people can go online and see if I have one. But I don't know if I showed up at Porter that they would see that before they'd already done something I don't want them to do, or not done something that I want them to do. So that concerns me.
Yeah.
Yeah.
It's a very complicated healthcare. It's a very complicated issue.
It is.
Yeah.
It is. And this advanced directive is only in the case that you can't, for some reason, communicate your desires to the
Yeah.
people around you.
Yeah.
Yeah.
Yeah, so you've been knocked unconscious or,
Exactly.
or
Yeah.
something like that.
Yeah.
Yeah. Yeah. All right. And let's see, do we have another issue?
Well, there might you might want to hear about mental health.
Yeah.
We almost anybody who reads anything has heard about the situations in our emergency departments where they're full of people who are mentally ill, who don't have any place to go. They need to be in a more intensive care situation, but there aren't any beds for them or any placements for them around the state. And we think we're getting closer to a solution, but it does involve building more beds. I think we've given up on not given up, but I think we know that we are undersized for the state. So we have a tentative plan to go ahead with that.
Yeah. Well, that's great. And thank you for coming and talking to us, and thank you for listening, and have a nice day.